Yeah, so for the physical therapist, it was really like, how do I take the skill set that I have and level it up into this environment? Do I have the differential diagnosis skills? Like, what are my impairments, functional limitations, participation restrictions? You know, impairments might be, I don't know how to do dry needling, or I'm not comfortable seeing really acute low back pain. So what can we focus on there? And then functional limitations, like how can we function in this setting? And we were able to find an dedicated treatment space. So this clinician can actually pull patients out of the waiting room, see them in this dedicated space, and hopefully just discharge them before they even take up a bed in the emergency department.
Rebekah Griffith, come closer. Welcome to the show here at AAOMPT.
Thank you.
You're somebody that doesn't feel like it makes any sense, right? Manual therapy. We're at a manual therapy conference, but congratulations, you just got your fellowship. You got your fellowship, completed your fellowship,
graduated.
Got your fellows. Did you get a sword? I heard people that get their PhD in Europe get swords.
No, I got a pin,
That's
which I can still poke people with that. So
that's
okay.
true. Yes. Yeah. Less likely to die with the pin, which I guess is good. Yeah. So congratulations.
Thank you.
What was something that surprised you about going through that process of fellowship? Because this was not, you were the person who gave me the most insight.
Yeah.
You had to travel and do hours, and you had to, this is not just, going through a workbook. This is hard.
Yeah, and I think I was a little less of a traditional candidate because I'm, by background, a neuroclinical specialist, not an orthopedic clinical specialist, and I primarily work in acute care, whether that's the intensive care unit or the emergency department. And so I think I was a little bit different in my cohort. So some of the clinical experiences that I had, I traveled across the country and worked in a hospital with a clinical instructor who did outpatient PT, inpatient PT, including the ICU as well as the emergency department. So I was able to get mentorship in all of those different roles. It was also really hard for me to go into that, the outpatient clinic setting because it's been so long since I've done that. But to be thrown into that and have to use that new clinical reasoning, that whole mindset of a fellow really was helpful for me.
You are practicing in a place that was maybe strange for a PT to be 20 years ago, not as strange 10 years ago, and now I guess moving towards more common, and that's the ED. You sort of alluded to that. When people see someone like you, PT in the ED at a place like AAOMPT, do you have to have that conversation explaining it anymore still sometimes?
I would say that less so, much less so. And I think we heard some content this morning pertaining to physical therapists practicing in the emergency department. I think people can see the value now. They can see the why. And so I think the more people see the why and the more routine it becomes, my hope is that people aren't you work where? That it just becomes so routine that it's a job you just apply for coming out of PT school. But I think it's obvious the role of manual therapy in the emergency department as a number one reason people come to the ED is for musculoskeletal pain.
Yeah, we talked to Claire Ardern before, and she said, typically it's back pain.
A lot of back pain.
It gets to the point where this is what we do in our health system, which is when pain gets to a certain level and I don't know where to go, and maybe I don't have a great relationship with my GP, or it'll take so long to get there, I wind up at the ED. Then what? Then they wind up on sort of off track, right? They're given meds because the people, no knock to them, people in the ED typically might not be prepared for that. They don't know what to do with it. They love, from what I've heard, a PT to be there and help them.
Yeah, I think the other problem is patients just don't know where to go. So we tell people to choose PT first, but they don't know that they should do that. And if you're playing soccer or you're out on basketball court and you roll your ankle and you're really not sure, is it broken or not?
Am I hurt or am I injured?
Yes, there's this danger zone that people don't know where to go except the emergency department or the urgent care. So we really truly need physical therapists in both of those spaces until people realize that they can go directly to a physical therapist for that. But one of the barriers that we have is that most physical therapy clinics can't accommodate same-day treatment or injury screening.
Or at night.
Or on weekends. So patients just truly don't know where to go. And I think if we can get in front of things, even more so in the emergency department than we already are, whereas we're seeing those patients first, we're making decisions about imaging, we're making decisions about whether or not we need to consult orthopedics. As the musculoskeletal experts, we really can get out front of a lot of those things when people come directly into the ED.
Okay. Let's give a preview. Didn't you get a couple of talks greenlit for a conference coming up in California in February? Are we doing CSM?
Yeah.
Two of them?
Yeah, and one thing I keep telling people is that I went 2 for 5 on my application. So for anybody out there who's I got rejected from CSM, I just want to encourage you that that's totally normal and that you should apply again. But one of the presentations that I'm going to give, which I'm hopeful about, especially with this group of folks that we're with this weekend, is manual therapy in acute care. So it's going to be called Hands-On in the Hospital, and really how we can incorporate manual therapy to our acute care patients as well, because that's not very traditional. And then the second is called Managing the Unmanageable, the A-holes of the emergency
You
department.
got to double click into the a-holes so we figure out what that means.
I know, and I really was not sure if that was going to pass the vibe check and if it was just going to get rejected based on the name, but people are already asking me about it. What does that mean?
What does the a-hole mean?
Yes. So what it means are, what are the holes or the gaps in the emergency department? Usually at CSM we talk about how to be in the emergency department. We're past that, which is so exciting. We're ready for real content on how to function at a higher level there. And so the holes that we're talking about in this particular case are altered mental status, anxiety, arrogance, all
A's
of those things.
all begin
Exactly.
with A, their whole, got it. Okay, good.
You got it. And one of the people that's presenting with me is actually an emergency department physician, and he was a DPT. So he was a paramedic, then a DPT, and now an emergency medicine physician. So we're going to get his input on how to manage those a-holes as well.
From a lot of different perspectives.
Correct. Yep.
That's fun.
Yeah.
What else are you looking for here at AAOMPT in terms of the content? You're someone who is a little bit like me, where you'll look forward to certain things and making sure you get time in. So what's on the docket for you?
I think I really want to specialize at being a generalist, right? Like I consider myself an all-patient therapist, so I'm going to go to a variety of different things so I can get new tools to add to my toolkit while I'm here. So I'm looking forward to some of those things and really about how to communicate better with patients, how to use your clinical reasoning in different ways, and hopefully we'll learn some new strategies to help our patients in the emergency department and other units of the hospital as well.
You do something a little bit different. You talked about how it's becoming more commonplace for PTs to be in the ED, and even people who maybe not practice there are just more common. They know about it more. They know that their colleagues are there. You also go into systems and essentially teach the hospital or teach the ED, number one, the why and the how into that. So you're sort of like a consultant in that. Talk about what those conversations are like. I mean, these people, where are they? Are they sort of sniffing? I mean, if they have the conversation with you, they're at least sniffing that maybe this is a thing. And then you need to prove like what it does, ROI. Like you need to get down to nitty gritty with people in hospitals who are, notoriously for a good reason, ROI centered and number centered. So you must have a lot of different types of conversation from the heart and also on the spreadsheet.
Yeah, so the last consulting trip that I went on was really great. So shout out to St. Bernard's Healthcare in Arkansas because they just started the first EDPT practice in the state of Arkansas. Wow. Yeah. And one of the things that I really had a great experience there was I got to talk to everybody on the systems level, right? Like I got to go into the ED with their clinician and be hands-on at the bedside. I got to meet with the rehab administrators and talk to them about what concerns they had. And also how could we even streamline the technology, the documentation for their new EDPT. And then beyond that, then going up to that C-suite level, the boardroom level. And that was probably the most intimidating for me to walk into that boardroom and really have to answer questions from those decision makers. So many times PTs want to go into the ED and they want to start practicing there, but the room where those decisions are made is much higher and we don't see that.
It's on a different floor.
Yeah, so what I usually tell people is you still have to go into that boardroom with the same mindset of a physical therapist. You have to evaluate, assess, and treat whatever the concerns are for that hospital and make short-term goals, make long-term goals, and make a plan of care about how you're going to truly integrate whatever quality improvement project it is into that emergency department.
So let's talk about this. Like from the clinician perspective,
Yep.
I work at St. Bernard's Hospital, right? And now what? I'm going to be in the ED. Like they must have concerns. Then there's managers, be they PTs or other professionals, and then C-suite. Yep. So what are the typical pathologies that you have to evaluate and treat from those three sort of avatars?
Yeah, so for the physical therapist, it was really like, how do I take the skill set that I have and level it up into this environment? Do I have the differential diagnosis skills?
Right.
Correct. Like, what are my impairments, functional limitations, participation restrictions? Impairments might be, I don't know how to do dry needling, or I'm not comfortable seeing really acute low back pain. So what can we focus on there? And then functional limitations, like how can we function in this setting? And we were able to find an dedicated treatment space. So this clinician can actually pull patients out of the waiting room, see them in this dedicated space, and hopefully just discharge them before they even take up a bed in the emergency department. And then really participation restrictions, we have to integrate that clinician into the community of the emergency department. So went with him to meet his community members. This is the nursing manager in the ED. These are the techs that triage the patients. These are the physicians that you're going to be working alongside. So we went and we really looked at how to improve his participation in his new community.
So he's not just sitting there in the corner and saying, waiting for a patient.
Yep.
The other people need to be educated.
Yes.
And understand how that this person can be used.
Right. It's like having a private practice in the emergency department, and everyone there is your community. So you have to understand your referral sources. You have have to understand where your patients are coming from. You have to understand the process flow and how your community works. So that was a really exciting time for him.
When you go up a level to sort of the people you were just talking about, management, other people in the community, what are their sort of concerns?
So our management, like our rehab management level concerns, right, are like, is this person going to be productive?
Right.
And then the next concerns are, where are we going to refer these patients? So if he sees these patients, how are we going to get them into outpatient? And if he sees these patients in the ED and then they get admitted to the hospital, how are we going to streamline that transition of care from the ED to the acute care unit? And then will this documentation need to be different than it is for everyone else? So we kind of tackled each of those concerns one by one until we were able to streamline that. The other piece that we did really to help integrate that was do a continuing education event with their entire community. So all of their PTs, their OTs, their OTAs, their PTAs that were working in home health, working in outpatient, working in assisted living, working on the rehab unit, working in acute care, they all came to the same continuing education event to learn about best practice in the emergency department. And why? Because that's the continuum of care. So if each therapist understands, we now have home health therapists who are like, oh, I could probably triage these patients before I send them to the ED. And then we have our ALF patients, or PTs, and I was like, how many patients are falling at the ALF that are being sent by ambulance to the ED that don't need to be?
Do they need to be?
And could you step in there? So it was really nice to look at how we'd streamline. And another example was, if we have a patient in the ED with a vestibular specific concern, which one of you is prepared to receive those patients that are coming out of the ED into the outpatient clinic? So that's how we hit that next level. And then onto the boardroom level, like those concerns are a lot bigger, right? Throughput.
What does that mean?
How fast we get a patient in and out of the hospital, specifically in the ED, right? Like how fast are we moving patients? Bedlock. Those are patients that are stuck in the ED. There's no beds upstairs. They're just stuck and holding down there. How can we expedite their discharge plans? Wait time. Like, can we get patients from the waiting room, get them evaluated, get them seen? Decreasing unnecessary hospital admissions, those observation stays, where the patients don't really need to be admitted to the hospital, but they need a discharge plan. Or they need a spinal brace, or they need maybe advanced imaging. But if the patient can help with, or the PT can help with differential diagnosis in the ED, we can avoid all of those different things. And then the last thing really is bounce back. Those are patients that are coming back into the ED because their plan of care, their discharge plan failed. But if they see a physical therapist in the emergency department, they're more likely to not bounce back because they get that initial care they need, they get some self-efficacy, they get referred on to the next best step. So those were the concerns that we talked to them about. The like highlight of that conversation though was one of the hospitalist physicians that was in that boardroom was like, wait a minute, you're telling me that you guys can start seeing those patients downstairs? I'm going to let all of our consult services know that. So if we get a consult for a patient for admission and we don't feel like there's a medical need, we can have you come and look at the patient from a safety perspective, from a vertigo perspective, from a pain control perspective. I was like, you sure can. So that buy-in came from the hospitalist level down as well. So it was really exciting to be able to have those conversations and try and lift them up at each level of the system for that buy-in.
The first time you ever were in a situation like that, because that hospital in Arkansas wasn't the first time you've done that, I'm sure you needed to be prepared, or maybe you were sort of hit with a question. You're like, oh, I don't know how to answer that. What am I supposed to say here? But you needed to understand it.
Yeah.
How did you prepare for questions like that? When you were hit with one the first or second time that you did a meeting like that in a place that you weren't, I mean, your famous line is familiar skills in an unfamiliar place, like bring your skills. How would you figure out how to answer C-suite level questions if you're not a C-suite person?
Well, partly when I started our EDPT practice, like we had to pitch it at those levels. So I think practice with that pitching, but also clinicians come to me all the time and say, these are the questions that they have. And so we'll look at the literature. There's great literature about how to integrate into the emergency department as well. So some trial and error, some practice. And I also try and like network at events like this. And if I talk to somebody who's an administrator, I'll say, hey,
if I were to do this, what are your
questions?
First three questions, and what do I need to pass the eyebrow test to make you go, huh? Let me go ahead with this.
Well, and I feel like as clinicians, we're like, of course, this is a no-brainer.
Right,
why would we not?
But you're answering with the heart.
Yep.
They have to answer with the spreadsheet.
Correct.
And the bottom line. And if you can't answer that overwhelmingly and not I think or I feel, like we've seen this, like you said, and of course the last thing I go to is the research because that's just not where my brain is. But hey, other people have done this, and this is what they look. I'm going to show another organization just like you or similar to you has done this, and this was the result. So as much as I can prove it, I'm proving it here.
And I think we also have great examples worldwide, right? Like we have clinicians in Australia who have admitting privileges in the ED and are practicing at such a higher level than we are in Australia and Canada, UK, Singapore, like all over the world. We're actually a little behind the curve here. So I'll have people from other countries reach out to me and they're like, we don't even know why you're talking about this. This is such a normal thing.
Yeah.
But then I still have to take all of their great experience and then apply it through that U.S. healthcare system filter,
Similar,
which is different. Yeah.
You spoke, where'd you speak? Singapore? Where were you?
Singapore,
That's where you were. How was that? I mean, let people know. I was texting you from there because it was interesting, but like explain how that was.
It was very cool. I got to present with a panel of amazing women who all practice in the ED in other countries. So our group was someone from Nigeria, someone from Australia, and someone from Singapore. And we took a patient case, the same patient case that could walk into an ED in any one of these countries, and then we walked through what the process would be like in each country, and we showed the differences and we contrasted them. Yes.
Yeah.
Yep.
That's cool.
Unfortunately, ours was the only country without socialized medicine. So in our case, I had to say, and we would not really be able to do much for this patient. We'd have to discharge them without the resources that they need, whereas even in Nigeria, where the poverty level is so significantly different from our own, the ability to discharge that patient safely was better than it was in the United States.
If someone wanted to reach out, find out more about maybe integrating this into practice or into their system, where would you send people to reach you?
info@theeddpt.com is my best email address, and you can find me on social media, EDDPT.
Perfect. All right, parting shot here. We'll do that. What's the last thing you want to leave with the audience today? What's your mic drop moment or soapbox statement? Or
we talk about transforming society, right? That's like our goal as physical therapists. We want to transform society through movement. But my argument is that we can't transform society if we keep waiting for them to come to us. We have to go out into the community and into society and integrate ourselves at every level, whether that's in addiction centers, whether that's in factories, whether that's in schools, senior citizen centers, everywhere. We can't just wait for patients to access us in clinics. We need to go out and find them.
We have to be assertive.
Correct.
We have to lead.
Yes.
Rebekah Griffith, appreciate the time.
Thank you.
Thanks for listening to Hands On, Hands Off, the official podcast of AAOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AAOMPT on social. Opinions are those of the guests and not official AAOMPT policy. See you next time.